So I wanted to thank everyone for coming. I know everyone's been doing a lot of work over the past few months, and I want to highlight some of the major accomplishments that we had. I know that we'll get into this a little bit more. Is Chief Smith here?
Chief Smith.
No,
There he is. He's going incognito.
Really innovative treatment programs, both within the jail and setting up support for people after they're released from incarceration. I want to thank him specifically for doing that and getting us really above and beyond and innovative stuff going on there. The big news in the past quarter, if you haven't heard yet, is the federal government awarded us $1.3 million in COTAP grant funding. What that's going to do is ensure that Hope Not Handcuffed survives for at least 3 more years. It's really a big deal. Hope Not Handcuffed is Annette here. There she is. So Hope Not Handcuffed has been Annette's passion project, and by passion project I mean she's literally done this for less than 20 years with no funding. And this COTAP grant, these are designed by the federal government to bring partnerships between the government and nonprofits, so that nonprofits can continue to do the good work that they do. Really pleased that they recognize how powerful the work that Annette's program is doing, and really it's our honor to partner with her and ensure its viability. So we'll have some more input from Annette as the meeting goes on today. Again, everyone else, I know Jill and her team, everyone over the past few months has stuff to share, so I don't want to take up too much time, but I see I'm on for introductions. Has everyone introduced themselves? Should we do the dais first?
Sure, we can start with Dawn.
Okay.
I'm Dawn Logan, Director of Prevention Services for Catholic Charity Orange Sullivan Officer. Jill Simon, Community Health Coordinator.
And what pillar are you?
We're the Hope and Education pillar. I am Karen Holden, Deputy Director of Public Health.
And? All right, let somebody say it.
Jana Walter, and I am the Supervising Community Health Nurse, and I coordinate the Maternal Child and Child Protective Services Health, and we are on the care pillar.
Melissa Stickle, Sullivan County Department of Community Services Director, and I oversee the treatment program.
How you doing? Nick Salomone, Legislative District 4, Public Safety Chairman, and I want to thank everybody for being here. What a job. I'm amazed. Thank you.
Good afternoon, everyone. Tom Farney, Commissioner of Public Safety, and the lead of the data pillar.
Little Commissioner of Health and Human Services. My partner is running with the Bulls in Spain or something like that right now. The same as Marty Colomino. But we work together on the United Sullivan Pillar Communities.
So I think just even with these brief introductions, you can kind of get a sense of what we've been trying to put together over the past couple of years. And the point is that the solution to the opiate epidemic is not going to be accomplished by one segment of our community alone. The problem starts with maternal child health and extends through whatever kind of death a person sees. Unfortunately, too much in our community is overdose. The problem has to be addressed then from all of those viewpoints. We've learned some shocking and scary things from maternal child health that I'm sure we'll touch on. And I look forward to kind of presenting this and to accepting the input from everyone who took time out of their schedule to be here, because what we realized a few years ago is that the same old solutions weren't working, and we need new solutions. But it would certainly be an act of hubris for us now to say this is what we can do. This is absolutely the best that we can do. We can do better. We want to keep doing better. So I really am so pleased to see so many people who took the time to be here. So I'm going to turn it over to Wendy for an overview, kind of year-to-date, what's been going on, and I think she's got a PowerPoint for us.
She does.
I'm very
And I must say, the ideas are collective. The work was Jill's wizardry, and if it wasn't for John from IT and the IT team here, this wouldn't be happening, trust me. So, okay. So,
Let me just get it started for you.
So for the drug task force, I read a really interesting story probably when I was, I don't know, my mother probably read it to me when I was about 3. But the other night, it came to mind, and I don't know why it popped into my head, but it did. Anyone familiar with the story of Stone Soup?
Yeah.
So I thought to myself, you know what, the drug task force is really the Stone Soup story. Stone Soup, I found out, was first published in 1729 in France, and they felt that it was actually a folklore that had been handed down from the 1500s. But anyway, and there are many iterations, different cultures that adapted the story, kind of put their own little ethnic twist into it. But the takeaway that I got, and that my mother really drove home for me, was the fact that everybody has talent. And the story in Stone Soup is that there are people that are very, very hungry and are starving, and they don't know how to get out of this. And somebody says, we can make stone soup. And they start, you have to get the book, it's a really cute book. And they start with this pot, with this stone. But what happens is, the community that in the beginning was kind of like, not my problem, all came and brought what they had. Somebody brought carrots, somebody brought spices, somebody brought some meat, and made this wonderful soup. And that kind of, if we can go to the first slide. Oh, thank you. If that kind of is a synopsis of exactly what Megan said and what the drug task force is, because there's not one discipline that can solve this. It's the collective talents of everybody in the county that come together and push us forward. Maybe not as forward as some of us would like to be moving, but you know what? We're a community, we're here, it's a Stone Soup, and this is the present structure of the drug task force. We started this 20. We revamped the drug task force, and this is probably the 5th iteration of the way it's been structured because it keeps changing. And I will take a moment to highlight briefly, I saw him on the I don't know where he went, but he's there. We recently, the newest addition was bringing Dr. Gold, a dentist, into the drug task force. So we're really excited. He's on the medical provider pillar, and we'll talk about that in a minute. Okay. So here is our summary. What I'm asking also for format, we're going to go through the whole thing, hold your questions, and then at the end, we'll open it up to floor discussion, and I'll direct the questions to the appropriate pillar lead, or if the pillar lead wants to take it, we'll go from there. I just want everybody to get a chance to see what we've done and celebrate our success. Well, hello, Senator Martucci. Very nice that you joined us. Okey doke. What? I did. Okay, so let's go to the first slide. This accomplishments of the drug task force. And this is broken up in the pillars. The first is the data pillar. This is probably, with the exception of the CARES pillar, the data pillar has been there, but thanks to Commissioner Farney and collective work, more involvement from law enforcement and the coroners and public health, we're really starting to look at some of our data. This is a summary, if you can see on the side, and remember this is a year-to-date update. From January 1st of this year to September 30th, 172 suspected overdoses in Sullivan County, 14 fatalities, and 122 Narcan administrations. The thing that's really interesting about this slide, and when you sit down the night before and you realize I should have put another one in there, I did that. The comparison of data, I don't have the comparison data for last year in there, for those of you that are data people, and I know will ask me that question after this presentation. It is a little bit like cutting your heart out. Okay, so the thing that I think really jumps off the graph in this, and it's probably a little bit difficult for you to read the back of the room, but if you look at 77 non-fatal multiple doses of naloxone to bring people back. It used to be 2 milligrams when we started doing this, and now we're up to 8. I think the state police carry now. So that's scary. And we can track that back to the bastardization, if you want to say that, of the drugs, and probably directly connected to fentanyl. Okay. I will also give a shout out. I saw her. Bernadette Wilton from HIDA is here. She's our HIDA rep and has really helped us pull some of this data together. This is confidential data, which is we get working through the CAC in Sullivan County, in Orange County, which is Crime Analysis Center. Okay, here's the TAC overdose report. This is something else that you hear, and you go into different meetings and you hear different statistics. And, you know, Jill and I pretty much know these numbers on our sleep, and we're like, where do people get these numbers from? In Sullivan County, and this is Sullivan County, and this is since January, the highest, the overdose rate, age rate, 20 to 50 is where the majority of them come. And as you look, 30 to 39 is the highest cohort of people that are overdosing in Sullivan County. And that's now. This could change next year. Okay, let's go on to the medical provider pillar. This pillar is unfortunately, no, very fortunately, headed up by Nick Batson. Dr. Batson is from Crystal Run, and he is over the addiction program, along with about 17,000 other things that this man does. He is absolutely fantastic. We had another wonderful Dr. Tucker Woods, who just had to step down because he got a really nice job in Manhattan. So anyway, the medical providers, and again, this is where I referenced Dr. Gold coming in, and also our pharmacy providers are now on this pillar. They've expanded across the county, including pharmacy and dental, like I just said, and active communication, because they really have been a resource for the other pillars. We've had some really good discussions about therapies and what would work and what wouldn't work. He also partnered with Megan, and they presented at the coroner's convention just, 2 weeks ago?
That's right.
2-3 weeks ago. So that's not only having the district attorney there, but having Dr. Batson there was a real plus. And I unfortunately was not able to go, but I heard the feedback was fantastic about the presentation. He also said that we're partnering now. We've been working with Catskill. There's been a little bit of a bump in the road since, unfortunately, Jonathan Schiller left. But we now are reaching out, Nick's reaching out to Dr. McGinley, who is the director of the ER now at Catskill. New York Matters is in the emergency room at Catskill. For those of you that come to these meetings on a regular basis, you should know what New York Matters is. And if you have a question, hold it to the end and we'll discuss it, please. What else do you want me to say? ER, we're getting good data now from the hospital. Unfortunately, what the data from the ER shows is low substance-related visits. When the people come to the ER, they're not getting that many people that are coming into the ER for overdoses. Data is showing that patients are being treated in the field by EMS with reverse medications, and then they RMA, or they refuse treatment. They refuse transport to the hospital. What Jill and I have seen, because we get all the ambulance call reports, or just about all of them, and we go through them, I would say easily maybe 45% of the 911 calls for an overdose RMA and don't go to the hospital. So that's an area of opportunity for us to project for next year, and there's some great ideas about what we can do with that. And his other plan is future pillar plans are to increase the number of providers and do better with our benchmark data. Okay, next we can go on to the Hope and Education pillar. This was submitted by the pillar lead, so this is conglomeration. Again, remember, this is stone soup. We have many agencies here in Sullivan County that are doing Narcan training, and the point is, it doesn't matter who does it, it's that it's getting done, and we're getting Narcan out to the community. So we have Sullivan County Opioid Overdose Protection Program, which is SCOOP, which Jill is also the coordinator of, works with the local other agencies, many of whom are people here, Dawn for One as a pillar lead from Catholic Charities. So you can see 44 trainings through the county, 450 people trained. I mean, you can read the numbers. I just wanted you to see what we're doing. We're really getting the Narcan out there. The really hot button here is salt. Everybody is familiar with salt, I'm sure. There's a lot of discussion about fentanyl test strips. At our last open meeting, we did a presentation about fentanyl test strips, what they were, how they work. Through SALT and through a grant that Aileen Gunther, who I think I just saw come in. Did I not?
Yeah,
Aileen, come, you're supposed to be up here. Come sit up here. Come. Over 1,000 fentanyl test strips have been distributed through grant money that Aileen was able to secure. And we'll talk a little bit more about that going on. Okay, next one. We talked about fentanyl. This is one of the promotions that are going out. DA Galligan has been recording ads, Sheriff has reported ads about fentanyl. This campaign is going out to schools on social media to let folks know about the dangers of the rainbow fentanyl especially. So we just need to get this information out there and tell people to be safe. Just very scary, very sad, but it's here, so we need to deal with it. Community United Sullivan pillar. This was a combination of two pillars. This used to be community services, and then, and John will talk about this a little bit later, there was a move to blend again the stone soup theory. So United Sullivan is a system of care that actively, and John has meetings weekly now for those of you that are involved. The project ensures that no matter how patients access the system, they don't get turned away. The other big item here, opioid settlement fund, dollars that we got. John and Megan have been working diligently to get that budget together. We've started to distribute money to several agencies that came forth with good ideas, Too Good for Drugs, SALT, wave your hand, Tom, to do some child outreach. Hope Not Handcuffs is getting money from the opioid settlement. And also, I'm forgetting someone who, money going to law enforcement to help with some technology, and I'm forgetting someone. I'll think of it now. I'll interrupt myself and tell you who to. Excuse me?
I have the whole list I can cover.
Not now.
What do you think?
Not now. Not your turn. Okay. Oh, the policy reform pillar. This is a really exciting pillar, a lot of stuff going on. For those of you that are familiar with government, we know how hard it can be to push that rock up the hill. We're very, very, very fortunate that Aileen heads this pillar with Judy Balaban, who's a community member, and her staff, Rachel and Matt. They've, Assemblywoman Gunther has been introducing bills right and left. We bring ideas to her. She works very diligently to see what's going to fly, what's not going to fly. We're able through her office to get resources from Albany and learn a little bit more about what we need to help put starch in the shorts of some of the things that we want to do. And also, again, as I referenced, Aileen's office secured money for fentanyl test strips to help save lives. We also do have some additional money coming in to purchase more fentanyl test strips. It's, you would think it would be a simple thing. It's not, going through the systems and the different governmental agencies to be able to purchase these life-saving things. Law enforcement pillar. So Megan already addressed the COSAP grant, which is it's just so, it's like so wonderful. Can't say enough. And then also a shout out to Hal and his team in the jail, working with Melissa Stickles' help and the team to get a real prevention program and treatment for folks that are in jail. We've been working really closely with Commissioner Forney's team from probation, a lot of good exchange, trying to get services there and help folks when they come out of jail, get right into a service or not have them kind of wander around, kind of that soft handoff. And also, we have an expanded presence on drug court. So actively participating, for those of you who are not familiar with drug court, and maybe Megan, you can talk about it a little bit when we get to your explained about drug court. And it's again, a good way to exchange information, to exchange services, and to make folks that are headed in the path of recovery make that journey a little bit easier. Treatment pillar, partnership with Bridge Back to Life. I see Julia Leibold in the back, and Lowell is here. This was an initiative that they brought to the county. Collectively, with Melissa's help, this program got up and running, and I believe the van is downstairs now. So if you haven't seen it, it's an amazing, amazing service. And this is to get access to treatment out to the far-reaching ends of the county for people that necessarily can't get here. Okay, and then the methadone maintenance program, dosing unit station in Lexington. Actually, they were supposed to be on the call. I don't see them. This is a project, for those of you that don't know, through a whole series of events Sullivan County did not have a methadone maintenance program. Tremendous amount of money being spent sending people out of county for treatment, and thanks to collective work on Monday, the methadone maintenance dosing unit station opened in Monticello, right in our office. Yeah, not in the office, downstairs. On 26 Hamilton. And we're really excited. They're great partners, and I think Melissa will talk a little bit more about some of the other things they're going to be doing. The CARES pillar, expansion of the maternal child health and child protective services program. Briefly, this is actually having nurses now, thanks to Janice's guidance and John's support, having nurses actually work hand in hand with the CPS team. And I'm sure Jan will talk about that in a little bit when it becomes their turn. And again, collaboration with other county partners due to the increasing need resulting from changes. This is a very nice way of saying, Barnett's not having OB services, so what are we doing with all these people that need perinatal care? This, we're all very proud of. We should all be very proud of this. Sullivan County won the New York State Broadcast Association Award. Old Gold Media won an award for outstanding public service. And then the Drug Task Force, so that's all of us, got a Serving New York Award. And then the next slide is, you can see on the bottom there, is our Hope, with Help Comes Hope. This is our campaign that's out, and this pushes our Hope and Referral line out to people that can access. And what we do when we get the calls is we listen and hook those people up with the best agencies that we think would be able to help them. It's answered 24/7, and a big shout out because this is done on with 2 paper cups and a string on nights and weekends. The public health nurse supervisors cover this call and help with it. Okay. All right.
Now you're back.
So now, let's go on to the 3-minute per pillar summary. And we're going to start with Commissioner Farney.
Thank you, Wendy. I came on board last year. Wendy approached me, sort of recruited me to assist in the data collection. I guess the task force onset developed a program to collect and record the data related to the epidemic, but they weren't truly capturing everything accurately. They found that the best to build their strategies were to accurately assemble and collect this information. She brought me into this. We started collecting it, and we have several meetings with our local police agencies, law enforcement, as well as other first responders. We streamlined the reporting where it all goes into one location on 911. This way, it's not being collected from different places. It reduces the redundancies. So now we got to determine where it was going. To our friends over at the CAC, and when we described the Hudson Valley Crime Analysis Center, they became the clearinghouse for it. They collect all the information and get it out to those needed. As you see, there's also programs that are available that we can track and monitor stuff. This becomes important because when you develop your strategies, you're able to isolate areas, some need more attention than others. But we didn't stop there. We wanted to make sure that the information we were collecting still was accurate. So we do periodically meet with members from the CAC to make sure they are receiving what they want and need. We also assigned a supervisor over at our 911 to oversee and do some quality control over it. Periodically, he will just match up the information that's received and check that it's getting filtered through accurately. This is a continuing process. We also saw early on that the original form of getting this information out to the CAC was via fax. That's not always the best option, so from that we learned and we adapted, and now we do electronic email. I really don't need the 3 minutes to go through it, the whole thing. But that pretty much captures the data collection and dissemination. This information is used and shared with law enforcement, again, so they can also strategize their efforts.
And we also have their officers from the Sheriff's Department that sit on that, 911 sits on that, and also Public Health is looking at And Karen, maybe you can talk about this in working in conjunction with IT, because another big piece of this is the analysis of the data that comes from the death certificates. So we want to be able to look at that, and a plan for next year is to be able to take this data and have an immediate response, so that if we know that there was, like I referenced, those people that walk away in Wendyland, what I would like to see is, we know where they live. I'd like to see a team go out to them the next day and follow up, or within 2 days, and follow up with people that have overdosed to make sure that they're getting what they need. Because you never know when you're going to hit that person, and they'll be willing, maybe they didn't want to go to the hospital that night, but maybe they'll go within 2 days. And that would not be something that, one agency could do. We've been talking with independent living, it's going to take everybody to get this done. Thank you.
I just want to make one more comment, probably it's the data, I think it's important to get this out there. For the first time ever, I was made aware of a self-Narcan administration. I never heard somebody going in OD actually giving it themselves. So this just shows you how the resources that are provided, the training, the availability of Narcan is important, and it's getting out there, and it's working. Somebody going OD and they're administered themselves.
And I think, as I said, Nick sends his apologies. He had something at the last minute that he couldn't make it, and I pretty much gave his report, so we can go right on to the lovely Hope and Prevention team.
Hi, everybody. So you saw the Narcan numbers that were up there. Jill will expand more on that, but we've been working with the LG district on the Too Good For pilot there. We are starting next Friday with their second grade classes to begin that program. We have teen intervening now running in Fallsburg, junior, senior high school. So when somebody is caught on school property with vaping or other substances, we get a call immediately and we go in. Louisa does that, she's online here, and she's been pretty receptive in getting in there, trying to get the first session in at least while they're still in school, especially to get that. We are working with Fallsburg to get the Girls Circle started. We're in conversations with the Monticello School District and Sullivan West about Too Good For Drugs and the Girls Circle. And we have a fabulous partnership with SALT, where we went to Fallsburg and we presented to 600 students in the auditorium, and we had another 100 students get the same presentation in Spanish, thanks to our partners at the National Guard, who were able to do that for us.
So we're also doing a lot of Narcan training. We do have our community training, but we're also, SALT, actually, I'm not even taking credit for it, is starting boots on the ground just in time Narcan training. So they're essentially walking the street and meeting people where they're at, talking to them, finding out if they need Narcan, and doing the training right with them, right at that particular time. So Narcan is getting out now more directly into communities where it's needed without somebody having to come to a class or even go to a pharmacy. The numbers that we had so far is it's already reached about 300 people, which is tremendous amounts of numbers, considering they only started doing that back in August. So we expect that those numbers are going to continue to rise as well. We are continuing our community trainings where we had last year trained all of the schools staff, but we now have more school staff reaching out and wanting to further that training. So we're looking to doing that. Wendy mentioned Rainbow Fentanyl. We are doing that education campaign. Megan has started doing some advertising on that. We're also, Dawn and I met earlier, working on putting out a fentanyl education program that will be geared towards parents of our school students. Fentanyl, Rainbow Fentanyl, regular fentanyl, we're seeing a lot in fake prescription pills. And unfortunately, we do know that that is not targeting, but it's affecting our students. So we really are trying to do education programming to make sure that people know what's out there, that they can be informed, that they can have conversations with their kids, so their kids know what to look for in college.
And you also implemented collectively the just-in-time Narcan training with the fire departments.
Oh, the Leave Behind?
Leave
Yeah.
Behind.
So we have Leave Behind. We just had another Leave Behind that was successful with our EMS agency. So they were able to assist that family. That was another person who received medical attention, but we were able to leave another Narcan kit should the need arise without that family having to go to a lot more effort or have to leave their loved ones to get a Narcan kit. So that's been successful.
And it was also expanded to the MCH program, so when they go into the homes, they're able to do that too. And also the Too Good for Drugs, the shout out Bob DeForest here. We work very diligently in collaboration with Catholic Charities with opioid grant money to get that program up and running. So, and Aileen also got us an audience with the, with, with the Vice Chancellor for New York State, who was very much in support of this, so we're very excited about that. Okie dokie, United Sullivan, Mr. Little.
Good afternoon, everyone. So to talk first about United Sullivan, we've evolved significantly as a pillar since we started. We were the community pillar at the start, and the idea was that we would bring in various agencies from around the county that are giving hope to folks through all sorts of means, whether it be housing, whether it be prevention, education, food services, all sorts of different things. We bring basically all of the cats and dogs together that exist to give people hope, because folks that are, experiencing depression and are, in dire straits, often turn to drugs to cope with whatever they're dealing with. So we work together as human services agencies to bring all of our different assets to the table to help each other, to help the community. And then something that's very important to Marty in particular is making sure that we are the conscience of the task force, that we are making sure that the community's input is received, heard, and brought forward to the rest of this group. So as I said, United Sullivan has evolved significantly, and first thing I should mention is that it is a concept that was essentially stolen from Melissa and the community services team, who have been working at the United Sullivan concept as a system of care for several years, and were held back, as everybody was held back during the pandemic. But it was originally built up as a mental health system of care. And when I came along with the social services team and trying to bring all these different agencies together, I wanted to make sure that the system of care was inclusive of the many things that contribute to health. And as many of you know, I have my own strategic design for a roadmap to better health for the county that addresses certainly drug user health, but also the broader issues of chronic disease, maternal child health, and so on and so forth. So we've worked on a variety of different issues, including supporting the Healing Community Study, which I know Melissa will be talking about some more. But as we've evolved, it kind of got to be an animal in and of itself, just keeping track of various meetings and assignments and things like that. So what I've done is sort of scale back and accelerate it at the same time. So the United Sullivan Group meets now weekly on Friday afternoons to get together, see what's going on with all the various agencies that are working together in the county, see how we can help each other out, see how we can make sure that clients are not getting left behind, because we want to make sure that anybody that enters this system of care that we're building is able to get the care that they're looking for, even if they come to an agency that maybe can't provide what they're asking for at that particular moment. So through these regular meetings, what we'll be working on is training for each other, mutual support for each other, and as Assemblywoman Gunther well knows, advocacy for the agencies, which I am constantly pumping into her office and into the state assembly and senate to get support for our local agencies and all that they're trying to do for each other and for the folks that are suffering.
Thank you, John. And I think when we open up the open discussion, we're going to be asking for ideas for the next phase of the opioid spending, correct?
Yeah, so
let me, because I know Aileen has to go.
Oh, okay.
Okay. So, Aileen and Rachel, I saw,
Rachel's here.
there she is. I see the hand behind the pillar. Okay.
And I had a day off before I began the game.
I don't blame him. Yeah, really. Okay.
He was a great kid. We have a number of notable successes as a result of our work, and I'm proud of what we've been able to accomplish. I have been able to introduce a number of bills which I believe helped with the opioid crisis. Last session, I sponsored a
8203-A. This bill will require DOH and Oasis establish a pilot program with at least 4 infant recovery centers in areas of need. These centers would assist with infants born with addiction. I also co-sponsored A348. The bill will require individuals diagnosed with opioid use disorder who are discharged from treatment facilities, state prisons, and hospitals to be provided an overdose reversal drug. These bills passed the Assembly, but not have been signed into law, waiting for Kathy Hochul to do that. Through our discussions, we also got an idea for a new piece of legislation that I will be introducing a bill to ban the sale of pill presses to non-authorized individuals or corporations. With the opioid crisis raging and the availability of counterfeit pills containing fentanyl skyrocketing, this legislation would aim to curtail the ability of individuals to possess, purchase, deliver, or sell pill presses. The bill will help to cut down on the influx of counterfeit pills currently on the market that are leading to many of the new overdose deaths experienced all over the county. Outside of our legislative accomplishments, we also work with Vice Chancellor Finn, Bob DeFore is in the audience today, on incorporating a drug awareness program in Sullivan County schools. Finally, I was proud to be able to work with the governor's office to secure fentanyl test strips for local organizations to hand out and save lives. And I just want to say that I'm all proud of all of you, and this is an awesome community, and with all of us working together, hopefully things will change, and thank you very much.
Okay, thank you.
I also want to say, if you have any ideas for legislation, the door's always open.
Right, people can join the policy pillars. It's a fun group. Melissa, you want to talk about treatment programs?
Sure. Regarding the treatment pillar, just for clarification, our whole mission predominantly is to provide access to care. And we've done that, Wendy made reference to it earlier, with Bridge Back to Life, with Julia back there. The Bridge Back to Life team has the mobile unit, which again is outside for everybody's view. And they go around to our community and bring the treatment to the people that need it, that can't get to it. And we're not importing these individuals. They already live here. They were being sent out of the county for those services. And anybody that knows anything about methadone, they have to go on a daily basis to get their medication until they're trusted or healthier, where they can actually take medication home with them. That's a big lift for a lot of our people. So we were able to, in working with Lexington, bring them to Sullivan County, and they opened their doors on 10/10, which I'm really excited about. They're going to actually have an open house later this month. And again, they already have a whole host of patients that will be starting, that are already our Sullivan County residents, our friends, our neighbors, all of the above. In addition, Lexington will be opening their doors up at our Liberty Clinic on November 1st, or the first week in November, to provide an outpatient clinic. They're assuming the drug and alcohol clinic that was run by the county. Lexington will be taking that over, and that's a win-win for our county. If anybody knows anything about drug and alcohol treatment, it needs to be very fluent, and it needs to be able to change on a dime, depending on the individual that we serve. When you work within a county, you don't really have that ability. It's very static and very hard to get changes made, where having a private provider come in and do it will actually allow persons to access that care and the needs to be met more readily. The other thing that we've been working on, this was mentioned also, close collaborations with Sullivan County Jail and Prime Care, and providing the MOUD services there as well as to different levels of treatment, which Prime Care will be providing. But what we're also doing is working a lot with the discharge planning. We actually have a monthly discharge planning group where we connect with and talk about the individuals that are in need, the level of care that they need, the access to, and that includes our independent living peers, our Catholic Charities peers, that help with the discharge and navigation of those individuals once they're released back into the community, to help with further success and recovery for those individuals. And I'll just make a quick note, John had mentioned about the Healing Community Study. That's actually going to be kind of fluent throughout the drug task force. As a healing community study has a couple of different initiatives that it needs to address, MOUD being one of them in the jail, healthcare regarding prescribing practices, and also behavioral health and access to services. And as I said, we're doing a lot of that already in the community, so taking those monies that through the healing community study and being able to apply it to what we're already doing and to enhance what we're doing is the end result of that healing community study. And I'm really excited about that as well. And a lot of my pillar leads will be aiding in making that and bringing that to fruition. The last thing that I wanted to mention, other than some things that we're going to be working on, is we're also looking to bring in a referral platform called Unite Us. We did a demo for some key leaders. And basically what happens with that quickly is, say an individual comes into, as John mentioned, it could be any provider in the community, say it's maternal infant, and they come in and we find that the mother is struggling and has some needs, maybe needs some food, maybe needs some housing, and maybe needs some treatment. Basically, what happens is you get an authorization from that individual stating that, yes, you can put my information into Unite Us, and it's predominantly their name and their date of birth, and you send out this referral to those resources. So, and these are registered providers, so whoever wants to be on this portal would register to be on it, and that referral would go out to these entities, and then confirmation would come in an email form regarding dates, times, and confirmation of those meetings. So again, it's all about improving access, and I think we're a lot of work to continue to do so.
Thank you, Melissa. I just see right now, Barbara, you want to just wave your hand so everyone can see you? Barbara is the area administrator for Lexington, and she couldn't make it here today, but she certainly is there on the screen. So now you know what it looks like. Al, did you want to say anything else about the services that you worked on in the jail?
I'm good.
Melissa covered that. There you go. Okay.
We do have 13 currently in the program right now.
Which is terrific, which is quite a jump from even 6 months ago. So it's very exciting. Okie dokie, CARES pillar.
We continue to face some challenges with our pillar, in particular with the dwindling provider population for both obstetrics and pediatricians, which is impacting our community. However, some positives. Seated to my left is the champion of our MCH CPS program, absolute champion, the heart and soul. Jenna Walter has been providing care to moms and babies and truly families that have been affected by substance use. With nearly 1,000 visits in a 2-year period. She really is phenomenal. Recently, she was promoted to a supervising nurse in public health, and so she brought on 2 more registered nurses in our CPS MCH program, which share the same passion for serving the community. They're working with healthy families, early intervention, MASN, First Way Life, Sun River, Safe Homes, and Health Homes, to name a few, and are actively referring to all facilities that treat substance use disorder for moms and any newborns affected by neonatal abstinence syndrome. I would just like everyone in this room to take a moment to reflect on how important it is that we serve the needs of our moms and babies in the community. There was a recent article published last Tuesday by NPR that referenced a March 9th report, which indicates that in our country, 7 million women of childbearing age and 500,000 babies will be losing access to care. That number is staggering, and we are facing these challenges in this community. We will be working with Commissioner Little. We have some interesting ideas that we hope are going to help address that lack of access to care. Not just access, but actually any available care. We just do not have enough people to service our moms and our babies. If anyone here shares this passion, reach out to me or Jana, and we would love to have you as part of our pillar.
Karen, I just wanted to jump in for a minute. I don't know, I might have missed it in your report, but at our last just lead meeting, Karen really shocked me with information regarding how many women in Sullivan County get any prenatal care whatsoever in the first trimester of pregnancy.
So those numbers that we get from the state database, they were pretty shocking. Of the 500 in some births of this year, nearly 87% did not have a visit with a provider in the first 13 weeks, which anyone who's had a baby knows how important it is that you are appropriately treated in those first trimester. Even just getting prenatal vitamins, just getting a screening, making sure you don't have any other, and every woman in here is nodding their head, and we need to do better. When we talk about our health outcomes, we talk about our health statistics, but it really starts in home, and home of those who are going to have a baby in our county investing. Investing in our future truly means that we invest in the moms and babies of Sullivan County.
Jenna, did you have anything you want to add briefly, since I skipped over Megan, and that was a big mistake?
Really.
That's right in my opinion. I just want to point out something that you showed us in your slide. It was kind of shocking to me to see that the greatest number of overdose age of 20. Remind you all to think about our child there.
The numbers are really staggering.
So, our numbers of babies that are born are for the veterinary company that's happy. What to do with this mom, because we got this referral from the hospital and she's supposed to have follow-up. And when I asked doctors and I would help her, she said, so that's what we're seeing. That's the common practice. Remember, these babies are our future. They're to start working more diligently with moms and babies, families.
And I will say, Dr. Batson was able to connect with a relatively new OBGYN at Crystal Run, who just came in, and the woman is just, not to get too graphic, I was there for a checkup, and while I was there, I took advantage, and she told me she was new, and I said, oh, and we started talking, and she's very much interested in getting actively involved, so Nick is going to follow up with her, or Dr. Batson's going to follow up with her, and now I must turn the floor over to our district attorney. Bad to brush over her.
I don't want to take up too much time. I do want to jump back to Karen for 1 second. I'm going to grab you again. Can you just describe for us, because I think this is really shocking information, and I want you to describe for us, because you can do a better job than I, with respect to statewide policy changes in the care of those infants from birth, with respect to how a doctor can now identify a child suffering from substance use disorder versus how they used to be able to.
I'm going to actually turn it over to Jana because she's been so involved in it, but everyone should hold on and leave here. Take a deep breath. Yeah, take a deep breath on first. So when we work with those who suffer from addiction, we don't want to stigmatize, not to break down that. Fortunately, there's a group of humans that are being affected by us working so diligently to break down the stigma, and that is unborn humans and newborns. So basically, it used to be that you could go to the hospital, deliver your baby, and there was universal screening. Everybody had urine toxicology, and it was everyone. It didn't matter what walk of life, what color, creed, you had a drug test. You can't do that anymore. So there's no drug testing for pregnant women who enter to the hospital screen to see if the baby is positive. So therefore, we're missing kids that may start withdrawing day 2 or day 3, and because of insurances, we're discharging with it. So we're not seeing those numbers, and those babies aren't getting diagnosed unless they're withdrawing really terribly, really early on. So there's a big gap that we need to focus on.
And our children the babies don't get treated here. For those of you that are not aware, they go to basically Montefiore St. Luke's, and Janet just or Westchester, true, so that's another burden.
This started in November when you watched our referrals directly. Whoop. So either suddenly, no one knows using substances, or it's directly related to the change. So that was very concerning. You have to have written consent to even ask. Even to ask. It's all the effort that's creating prevention, referral, and treatment. I know, we can't do it anymore, right? So the effort, you can't say, hey, it is now as of November of 20. Not appropriate to do that. So we're struggling with how we can reach and connect with people. How can we even screen them during a pregnancy when the provider offices, of which there are not that many anymore, are not even allowed to ask those questions?
And I hate to dwell on the topic, and I know everyone's time is valuable, but Janet, and I know you're suffering a migraine, but can you explain for us, because I understand from having spoken to all of you, that different doctors take different approaches to children who are born addicted, right? Some say you have to test out to a certain degree, but what is the value in knowing immediately, and what could happen without them?
So the worst that can happen is a baby goes home and the withdrawal symptoms don't start, until 2 to 3 days after. That baby can suffer cardiac problems, and these ones are scheduling with a pediatrician, let alone when it's probably not. So there are some very severe consequences of not knowing. The long term, learning disability, ADHD. So the earlier we can get help and this, continued screening, the better the outcome for that child, the more services for moms. So moms don't want to lose their baby. So if we can keep moms and babies together, we can provide support, we can, make sure moms staying in a program. Women tend to remain successful in treatment if they're able to keep their children. Kids might from being diagnosed, what kind of school might fall down, right? So, being able to even ask that question, that's where that screening and brief education to a pregnant woman is so important. And we kind of lost ability. We could get a woman into treatment before she delivers. A woman who uses a MAP program or an MAP program maintenance, the baby still has the potential to have NAMs or a withdrawal syndrome, but it's a more controlled, more static, as opposed to the woman who is binging and purging and binging and purging. And think of what that does to the nervous system of the adult. Think of what it's doing to the nervous system. So, have a solid MAP program is much better for the pregnant woman to be on a methadone program or and to get on the street. So, trying to figure out how to reach those women, how to reach those families. I want to work with you a little bit more in the jail, and we get involved in drug court so that we can start, having conversations and not, pointing the finger conversations. Hey, you're a child bearing abuse. We want to have.
Thank you, I'm sorry for dwelling on that.
No, it's, I'm like standing here flipping, so that's great, no.
I'll jump to the law enforcement pillar now. Wendy asked me to mention drug court. If you're not familiar with drug court, it's designed to provide people accused of crimes with an option to enter into a diversion contract. The contract exists between a team of drug court representatives, the court, the defendant, and the prosecutor. And the agreement provides a carrot and a stick. Be guilty to a certain charge or number of charges, and if you comply with the program and successfully complete it over the course of 12 to 18 months, sometimes even more, you get a reduction in your charge or your sentence, whatever the contract calls for. And if you don't, then you're bound by your original agreement. In drug court, we've seen tremendous success. What we've seen since COVID and policy and legislation changes that have affected the criminal justice community is less interest in entering drug court, right? We used to use drug court in circumstances where a person would say, for example, I don't want to go to prison, but I'm not voluntarily getting treatment, things like that, and they're in jail with Hal. Hal will call up and say, hey, maybe get this guy into drug court. They could go visit the guy and explain the program to them. And we were feeding people into drug court from jail, and the court was putting them into mandated. That's much more difficult to effectuate when people suffering from substance use disorder are not in a place where their lawyers can get to them and have that conversation with them in a controlled environment. So getting interest, getting people to engage with their own lawyers and with the drug court team has become more difficult over the past few years. However, those people that do enter generally successfully complete. We see many more successful completions of drug court than we do failures. And I think that's because we put together a team of people to continuously monitor and support them. And our presiding judge, Judge Schick over drug court, understands that relapse is sometimes part of the process and really exercises tremendous discretion and judgment with respect to either continuing people or terminating them from the program. What we tried to do over the past few months is expand the drug court treatment team so that more stakeholders from the community, from the drug task force, are involved in trying to intervene with someone and bring them additional services. Melissa has been there since the beginning, So she is probably the person in this room most familiar with how the treatment team operates. But if we can bring together more people, like Lexington, like members of maternal child health, things like that, we will have more success in intervening for a positive long-term outcome. What we've seen certainly is more success than failure in drug court, but we've also seen a year later, someone come back. Maybe I need drug court again, or maybe this time I've gone beyond what drug court can offer. So we need that discharge planning, like Hal has talked about so much over the past couple of months. So that's a little overview of drug court. A lot of developments going on with respect to the law enforcement community and the drug task force. First, I guess I'll go over some things before I call up Annette and Steve. I'm going to call on them in a little bit. But we did partner with the Orange County DA's office. They executed. So part of law enforcement's job, right, is not only to treat the person suffering from substance use disorder and try to divert those people suffering, it's also to remove those who profit from addiction from the streets and from the community. On that side, we partnered with the Orange County DA's office. They executed an eavesdropping warrant, and we recently took 127 grams of fentanyl from a home in connection with execution of search in the village of Monticello on Hawaii. That's enough fentanyl to kill thousands of people. So, and it's right here in our community, packaged, by the way, in a candy box. So that's on the law enforcement side. That's a very important part of the work, and I want to stress that. Our opiate funding plan that John worked so hard on does include supports for law enforcement and programs that we need on that. But on the other side, Hope Not Handcuffed and education of our police with respect to what we can do to help those who are suffering is equally important. We had a very long, where are my investigators in the back there? We had a couple hours last week we spent with Juan Figueroa, the Ulster County Sheriff. You know, Ulster County has implemented an Oracle program. What we also learned from Juan is that he himself, as the Ulster County Sheriff, employs a team of social workers. How innovative is that? They work directly for the sheriff. And what the sheriff does is refer to them interactions from the community that lead to a basis to believe these people need help. Whether that's the police were there last night and Narcan someone back and the person refused medical treatment, whether it's a sheriff's deputy who had an interaction with someone on the street and sees that they're actively suffering, the sheriff himself will dispatch social workers in safe conditions to go to that person's house and try to intervene. That's incredible. And what Ulster County has seen since they implemented this scheme is a 30% reduction in. So that's really incredible. And it kind of blew the minds of my very seasoned police investigators. And ever since that time, we've been working on ways that we can try to implement some of the successful portions of that program here in Sullivan County, mindful of the fact that we have tremendous constraints on our. So that has been really an eye-opening experience over this last quarter of the drug task. Of course, as we said earlier, our most tremendous accomplishment of late is our COTEP grant. I'd like to invite maybe to the podium Annette Card and Village of Liberty Police Chief Steve Data to talk about how important the Hope Not Handcuffs program has been and what the grant will mean to us going forward.
Mike, is this mic on? If somebody taps it, we'll know if you can speak from there. If not, there you go. Okay.
I was asking Chief Degana if he knew that we were speaking.
No, neither of
No, none of us knew, but it's a good thing.
Yeah, so all of us are very excited to have secured this JA grant, which is going to mean a lot to our program. The grant is, and maybe I'll do that. We talked about the grant, and she was just like there was no questions asked, and so we.
It's a no-brainer.
Yeah, so we went for it, and we're really excited to be able to have that. So essentially, it will enhance what we're currently doing, the deflection type work that we're doing, which is generally trying to get people before they enter into the criminal justice system, and they have not committed any crime, and maybe they're just out there suffering and finding treatment through law enforcement as a path training program for law enforcement. It is a paradigm shift, right? We've seen this over, I think, maybe the last 10 years when this type of work started. So that will help enhance that part of it. And then, of course, our diversion program and enhancing that and making certain that that runs the way we would like it to, and all of it takes funding. So this is just the first step with that. I do want to say, just a little shout out to Chief DeGavis. So this type of work is actually sort of began in 2015 by an organization called PARI, which stands for Police Assisted Addiction Recovery Initiative. They have a summit annually, and they have bestowed us the honor of being, they're going to recognize us at Boston University next month, and they asked me to invite one of the police chiefs that we think is sort of an exemplary, part of what the work is. And so I have asked Chief DeGavis to go with me. Of the 60 law enforcement agencies that we currently have with this program, I just feel like he really gets it. He has been so important in the work in every way with his initiative about the community. So he's going to be participating on a panel with me, and will be recognized. There's 6 chiefs that are going all together, but only Chief DeGavis will be part of the
So, ever since we began our collaboration with the Nat and Cochon success, I think, in the county, been able to observe it in the Village of Liberty. The key really is trying to get that paradigm shift from my perspective from the police officers. We've trained into our police officers for decades that they're a hammer and everything is a nail. Everything looks like a nail. So getting that mindset to shift has been the most challenging and the most rewarding aspect of working with this program. And I think it also is a snowball effect. The more, because police officers are very skeptical of new things. We really don't want to do things. So the more we see the success of the program, every time that we see someone who successfully found treatment, another officer kind of perks his head to the side, maybe he was skeptical, and says, okay, maybe there's something to this, and I should pay attention. Excited to continue to see that snowball take steam and build momentum and to continue with the program.
Thank you. Thank you both. When we talk about these paradigm shifts, I think the last thing I want to touch on, and we touched on it already, is this incredible mindset shift. And he looks away as if he knows I'm going to recognize of Chief Smith from the jail. You know, the jail used to be looked at as just somewhere where we put people too dangerous to be on the street. And now it's not only somewhere where, dangerous offenders or people who can't go to jail are, but it's a place where those people are given a chance to change their lives. And that's been incredible. I got my first few phone calls, and it was really eye-opening even for me as district attorney. Someone from the jail was calling up. That happens 100 times a day. And I pick up, and it's a discharge planner who wants to talk to me about what kind of community support someone's going to need because he's going to go to. That's incredible, and that comes from the top down. It really does come from Chief Smith, getting people medicated assisted treatment, getting people mental health services. We really haven't even touched on that. He's really dramatically increased the amount of therapeutic services to people in the jail, and then that discharge planning. We just never talked about it before, and now that we're talking about it, it seems like a no-brainer again. Like, why weren't we talking about it? But now, when someone gets released, we don't expect it to, which really has been a tremendous success, and we really can't say enough good things. And Chief DeGavis mentioned that kind of paradigm shift. How long have you been at the jail?
38 years.
So it's never too late to try something new. And getting buy-in, Annette talks about this a lot when she goes and trains police departments. It's really hard. My guys talk about it. It's easy to turn around a speedboat and really hard to turn around a cruise ship. How's operating a cruise ship? you know? So turning that vessel around really required a substantial buy-in from Hal that he pushed downward to all of the deputies at the jail. We're really proud of that development as well.
That's very exciting. And I can tell you, because I sit on drug court, when I read something, because they put reports, the folks that are involved in drug court write reports about where they're doing, and they go to different levels. I have to tell you something, I cry when I read some of them, because they really, like the gentleman that you potentially could have seen on the promotional ad, they really talk about how their life has really, really turned around, and the people that have really touched them, and a lot of it comes from the folks in jail, and the people that work in the jail, and also a lot from probation. Tremendous amount of positive stuff when they reference probation. So, all good. If the team up here is done, and I will say yes, they are, I would like to open it to questions from the floor. John, did you want to talk about your idea for the opioid, what you'd appreciate people doing for the opioid settlement money?
Sure. So, as many of you already know, we put together the opioid settlement fund 5-year spending plan that I put to the county legislature back in the summer, which they were gracious enough to approve. And that was always designed in mind, or with the idea in mind that it would change as we went. So even though it's a 5-year plan that takes us into 2027, if you're familiar with how these government budget plans work, it's very much like a capital plan that we will look at it, and we want to see what we need to maintain over a longer term, but we also want to be able to adapt as things go. So we have a list of things that we're planning to spend on this year, and we're still waiting for some of the funds to come in for this year. But we're also expecting additional funds that we're not even aware of yet, for example, from Purdue Pharma when that lawsuit finally settles, to add a substantial amount to what we're able to put out the programs through these settlements. So around this time last year is when we built the plan that was approved in July. So I'm ready to start that cycle again, ready as I'll ever be. And I would love to hear from the community more. We certainly took inputs from all the pillars to put together the plan that we had, or that we have right now. But I know there's also, when you put yourself out there and you offer something up and folks get to see it in public, it prompts new questions, and folks that could think they could do it better, know they could do it better. I'm sure people could do it better than I could do it. So I certainly welcome all those comments. And as we get started the new budget cycle for the opioid settlement, I would encourage everyone to feel free to reach out to me and or to the various pillar leads, and we'll be working on it.
And I think what we'd like you to do, please, I know there are a lot of good ideas out there. Please put it in an email, because we did get quite a bit last time, but a lot of it was, well, it would be a good idea if somebody, quote unquote, somebody did this with no real structure. Everybody out here are the content experts, so when you bring an idea forward, it's really helpful if you have an idea of how it would roll out. If you could throw some financial things behind it, again, your areas of expertise, that just makes it easier going through the process. Because we got some really, really interesting ideas, and John and Megan worked very hard to get a lot of that through. I will say up here, there's information for Hope Not Handcuffs, and also Hope Not Handcuffs has a support group. So please take this information out there. Take it with you. If you need more for your organizations, just let us know. We'll. Annette she's got a car full of stuff. So, and now so do I. So we have lots of information. What about questions from the group? Yes, Miss Lerner. Wait, you can come here. I'll bring you. I'll be Vanna. Oh, yeah. Oh, that's right. Thank you, Ken. Go to the Ken podium.
Just have a few.
I thought you might. Bring it down, your little.
Thank you so much, Wendy.
So the first is there, and it's to Tom, to Jim, and to Dawn, is there any correlation between Narcan training, the increase in number of people that are being trained, and overdose deaths? Any correlation in that? Perhaps year over year, we might be able to see some kind of drive when we look at more people training and less deaths.
Well, that's something as it starts to me, we can monitor to see if there is any.
Okay. But that could prove the benefit of Narcan training. Right. The other is, and maybe this is just a point, recently in the paper, there was a robbery in LaGrange, at a Walgreens, where two people jumped over, the counter and stole all the medication. So do we run a risk here, just like we do in banks, where they put out these safety glass, perhaps something that we should look into as well, just as a list. There was a new bill signed into law by Adams in New York City. I don't know whether it's needed here, but just certainly for discussion. And that is, the new bill was to food establishments and bars, where they would, maybe Wendy, you already brought this up.
This, I think, I'm looking at the pillar and knowing Rachel's behind it. This was already, the policy pillar already has that.
Great, great. I'm stunned by the 87%. I mean, that's absolutely blew me away. As you talk about stone soup and people getting involved, are there earlier intervention when we look at whether people are being an overdose, for example, or any other ways that we could track this more as an early on intervention, whether it's through food stamps? I'm not suggesting that we could even go that far, but are there other ways that we can identify women that are pregnant early on in the process? And that kind of ties into the 30 to 39 range. When you look at those numbers, how many are male, how many are female? Do we know that data?
We can get, we do have that data. We're limited by how much data, how much we can drill down, but yeah, we do have that.
Okay, thank you.
It's men. It's men. I think, I would say, I don't know, I'm looking at people who look at the numbers as much as I do. I would say it's almost 2/3 to 1/3, 2/3 male.
2.5 to 1.
There you go.
Okay, thank you.
Anybody else have a question?
No.
Can we speak to that last?
Oh, of course. Wait, oh, we have a question from behind the pillar?
Yeah.
So, is it something that's popped up? Oh, I'm Camille from Senator Murphy's something that's popped up with constituents, and it kind of pops into the 30 to 39 range. Also, young mothers that, all right, with any other disease, there's always trying to get early access to resources, early intervention, insurance. I'm sure I'm going to make everybody cringe at that word. Constituents over time, and there really wasn't anything I could do besides send them to people with more information, have jobs, and were looking for coverage, and it wasn't covered by their insurance, but they didn't want to go on Medicaid, and they want to keep their life going. So that middle ground for having an early intervention for somebody looking for resources, what do we do there before somebody gets on Medicaid and then they're covered with everything, and they still have a little bit more of a chance early on?
I think that's, Camille, that's a fantastic question. And that's something I think I've harassed and worked enough with Melissa over the past 15 years, probably over the last 10 years specifically on that issue. Because Melissa is tremendously versed in insurance rules and regulations, both public and private, and there's just a big gap. Maybe Melissa, you can speak to that. Often it winds up with, well, if he gets arrested and the judge orders him to treatment, insurance will pay for it, which is not the right answer. So
No,
maybe Melissa, can you do something?
The answer we have to deal with.
Right.
Yeah, and unfortunately what happens, what we do a lot of times when it comes to insurance is a lot of agencies, and particularly the agencies that we work in Sullivan County, we have individuals that work on sliding scale. So that, again, if their insurance won't pay, we try to meet that. So there's always that option of sliding scale. The other thing that we also try to do is, and many of us have now have what we call insurance navigators, which are on site. I know they're at DSS and other locations. And what happens is if their insurance is not adequate through their job, we can have them meet with an insurance navigator and get a different form of insurance that will meet their needs. So there's a couple of different things that are going on, as opposed to having to say, well, go to jail and make it court ordered, and then your insurance will pay.
Well, then it'll be tough, yeah.
We don't want to do that.
an insurance navigator. Does that
Insurance navigators.
in other counties?
They're out throughout the county, we have them in different locations.
Great, thank you.
Even those that are insured, though, they're often the physician or the OBGYN does not take that insurance, even when we think we have good insurance. I mean, there's a lot of changes that are going on in something in this community that what they'll take and what they won't take. And, you know, we all fight to have it, we pay extra money and everything, and it's difficult, and the co-payment is just exorbitant. So what happens is people don't go because it's either food or a doctor.
And with insurance, the thing I like about insurance navigators is they'll sit with that person and go over exactly what they need and try to find an insurance policy that fits their need at that moment, that they can afford in addition to.
Right.
Again, I'm not gonna say it's 100%.
That's something, certainly that's been a hot topic for many, many years. You know, I've seen it with Melissa so often, and often insurance companies, particularly private insurers, require you to fail at everything else before they authorize you to go inpatient. And we know, and the data proves, that if you have opiate use disorder, substance use disorder, outpatient treatment isn't going to help you. So, but first they will only pay for, you know, nighttime, once a week treatment, then you fail at that. Okay, now we'll pay for you to go to days. Okay, then you fail at that. We'll pay for, you know, 72 hours a day, and then a 30-day stay before you're actually authorized for the months and months of treatment that you need.
Companies have the past, just prior to the pandemic, are not supposed to be able to do that anymore. So if that continues to happen, I have no problem calling up insurance companies and yelling at them.
We have fewer and fewer OBGYNs in our community at this point. Fewer and fewer, so it's even hard to get an appointment. We've had calls in our
Use the
office.
mic, Aileen.
I said there's fewer and fewer OBGYNs in our office. And again, there's a lot of these large corporation healthcare systems that are not taking these insurances. And it's kind of, and if we talk about the health of our newborns and those things like that, and you know, those visits are so valuable because during each visit, you're actually educating that young mother or a mom, you know, whether it's breastfeeding and how good it is. You know, I mean, I really do not like insurance companies.
I think Karen is about to explode. Okay, so,
I know that the focus is supposed to be, of course, from substance disorder, but I'm really getting our hands around the entire issue of moms not being able to get care is really important. And I think as a community, we need to look at, you know, do we give our employees time off for those doctor's appointments? You know, I only get so much time, I'm saving it for when I have my baby. And I think that we need to address the way that we let people work in a hybrid situation. I think that we need to be very, very, like, arms around this entire issue, not just for those people that are suffering from substance use disorder, but really making sure that our moms are set up for success, because it sets up children for success. It sets up our community to be successful.
Great people, like they say.
That's gonna happen.
Great people,
It's so true, like, we're over here like, So, you know, while I'm here for drug task force, obviously, maternal child health at Sullivan County sees everyone. The problem is they don't get referrals for those folks. And when you talk about insurance, we are one of those agencies. We supply nurses to the home, to home visits, we do annual assessment, post-natal assessment, for the newborn. And we do work on a sliding scale, so it's like free and reduced. But we also then hook our families up with facilitated enrollers and help them get insurance. Also, if we don't have a provider, doesn't have access to a provider, we work with all the community support agencies to make sure they work under doctor's orders. We have no doctors.
go ahead.
To characterize the constituent.
Come up to the mic a little bit more.
Just to characterize, the constituent I worked with wanted treatment and couldn't afford it. So at Catholic Charities for intensive outpatient without being covered by insurance was the out-of-pocket.
Wait, in the back of the room, we have Amy Kolakowski, who's the Director of Catholic Charities. Okay, Amy, come up, because nobody's going to hear you from the corner.
So Catholic Charities as the navigator, and it's either low or no cost.
Amy, come up to the mic, please.
Loud enough. I'm
You're not.
in person. So Catholic Charities can actually treat for low or no cost. We also will work with the navigator because we know that it's not just about the assessment visit. It's also insurance pays for MAT, it pays for medical care, and they pay for additional mental health care. So insurance is essential, not just to get in the door, but for long-term continuing care. So the other thing just to put out there, our medically supervised detox also takes people, no insurance, no reimbursement. So just, if you have someone in need, absolutely, they can walk up at any moment. That's what we do.
And you know what, I'd like to, Annette, do you want to talk a little bit about, because about the Hope Not Handcuffs, what the angels do? If someone comes that has no, you have to come up to the mic, I'm sorry. Because I'm not giving up mine.
Something about a microphone, I get like, oh, I talk real loud when outside of a microphone.
So,
Just,
Camille, just, you're going to hear some more interesting information here too.
we will initiate, so we'll work with anybody, whether they have insurance or not, we'll initiate, Medicaid. We work real closely with insurance navigators too, so, and then, we will do that. If anybody needs help, obviously that's the point of the referral, self-referral program, they can walk into any police department in this county and just ask for help, and then we'll send to, trained volunteers over called Angels, and they will, they can do that right with us. They call our whole line. We have 9 peer recovery coaches, that are certified and on our phone lines, and they will initiate insurance and everything else from there.
It is, it's really an amazing, amazing program. Beep, 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 beep.
Wendy.
Oh, and then we have an exploding commissioner over here, so could you you finish and then we'll,
This will be it.
Okay.
Of that 87%, how much is fair with the same concept as Hope Not Handcuffs? If they come in for care, is there a fear that they're going to get arrested? So aside from cost and insurance, how much is fair?
Fear?
Fear, I think fear is not something that we can really measure, but it certainly is relevant. I mean, I don't feel that there's a really good understanding that we are not taking them in.
Okay, so that's the paradigm shift that you talked about earlier.
So, I can only speak from my lane and, but if they walk into a police department, the reason that the police department is a part of our program is because they have made the commitment that that's across the board. Like, all the police departments that we work with, we've never approached one. They have all initiated this on their own to come and do this type of work. Like I said, it's a nation where people, that's just number one. But obviously, that fear is there, and there's definitely. But they can also call our phone line every 7 days a week.
yeah, numbers are up here too, take the cards.
Our phone line is 7 days a week. We have people on every single day. Actually, 2 people from out. One is coming out of Rockland County jail, and then another person from the county who's working the online, and we'll help them right over the phone. Or can't get to a police. Or they can go on our website, and we have a form on there, and they can just fill out a little brief information.
Thanks, Annette. John, and then Scott, you look like you were having an exploding moment also, so.
I'm always having a floating moment.
Well, let John go first, because there's steam coming out of his ears, and then we'll go to you, okay?
Sure. I appreciate it. So, you know, from the county's Health and Human Services Commissioner's perspective, and this is, if you're not familiar, that's public health, social services, and mental health. I can go even broader to what Karen and Janice just said, because the thing that really strikes me is, you know, 95 cents of every healthcare dollar in this country goes to resolving care issues. 5 cents on every dollar goes to prevention. That's a huge problem in this country, and here's why that really matters here with what we're talking about, because when we're in a situation where it's hard to find care from an OB, it's hard to find a family practice physician. We already are in a situation where, because of the pandemic, folks are reluctant to go to hospitals, reluctant to go to urgent care, so on and so forth. And we as a culture have kind of gotten out of regular doctor visits. I mean, I remember regular doctor visits when I was a kid. You know, you could go to the doctor's office. That wasn't something that people seemed to really think about when a lot of us were younger. Now it's, you know, it's a pretty serious financial decision. And it's not just a financial decision because I'm not sure if my employer's insurance will cover it or if I can pay the bill out of pocket. It's also, can I afford the gas money? Can I afford the time to drive to Middletown, Newburgh, so on and so forth? You know, I'd be remiss if I didn't point out that, you know, I don't see a rep from the hospital here. And that's a significant issue that we all need to be paying very close attention to, because making sure folks are getting the preventive care that they need, whether it's through primary care, OB care, chronic disease care. These are things that can be solved before they even become the crisis that they are. And we as a community need to bound together to work on those issues as well.
Well put, John, thank you. Scott?
Yeah, it was just real, I'm not even gonna go through my list because you said send an email, so I'll send an email. Just a quick question in regards to drug court, and I could obviously find out my answer later, but I have to know now. Do you have a peer in the drug court?
We do. We have a peer support in the drug court. It used to be supplied by cafeterias. Is it still, Melissa?
Yeah, there's recovery.
Yeah, there's a peer recovery coach from CAF. I want to recognize someone who I know rearranged her schedule to come, that's one of our former directors of public health. You can come up and just introduce yourself, and I think it's helpful to hear that perspective, because when we talk about how far we've come and how far we have to go, I think you have
Thank
a
you.
great...
Diane Campbell. I was the public health director until 2000. And then after 2000, I was involved with the Children's Mental Health Program, which I started going. I was the administrator for MISN for a couple of years, and then I recently was teaching disaster planning and community health in the West Indies, which I can't recommend highly enough for everyone. But anyway, going back to one of the things I haven't really heard, and I apologize because I've been out of the country and for various reasons, just sort of now coming back and really informative what's going on. One of the issues I haven't heard about was child abuse. And 45 years ago, public health and the schools and social services, we created a child abuse task force in the county. And I don't know if Parents Anonymous still exists here, but especially around substance abuse, the parents, you know, caregivers, whatever, don't have the skills, don't have the ability to really care for a child. The children, you know, are, you know, young kids or substance. So child abuse is one. The other thing was when I was at public health, no doctors were taking Medicaid. And what was the services that were going on at public health at the time? We had a WIC program, we had home visits going on for maternal child health. We screened all birth certificates, we just did all first mothers. I mean, there was a lot of NCH activity. But again, if they had Medicaid, doctors weren't taking them. So what we did was, I went to every physician. There was probably three, but anyway, probably 3 or maybe 4 people that were doing deliveries in the county. So what I did was I said, look, it was sort of this like share the care burden, right? Everybody didn't want to get all the Medicaid. So they trusted public health, right? So I said, well, how about if we with the WIC program, delegate, Dr. A gets one, Dr. B gets one, Dr. C. And they did, they said yes. So that's how we got people into care with the promise that we would create a prenatal clinic. which we did, and we had like an amazing prenatal clinic, 150 high risk. And the configuration of the prenatal clinic was that the hospital did all the lab work and all the deliveries. Dr. Brzlowski and Cohen were on contract to us. We did all the visits. We had this tremendous success at the time, right? And the county, this is the danger, the county decided at the time, if it's not mandated, you can't do it, right? The other program that we had going on at the same time was teen parenting. Remember the teen parenting? So now we have the teen parenting program that there was not one repeat teen pregnancy in the 2 years that we had these kids on our, this is unheard of, right? For the teen parenting program, so again, the county's like, it's not mandated, you can't do it. We had to deal with the teen parenting program, right? That's driven into the ground. We had to give away the prenatal, we had to stop the prenatal clinic. The hospital was chomping all day long, the prenatal clinic. Never happened, never opened it. But I would say that this share the care, if you can get the few physicians that are currently doing deliveries, and if you can, through WIC, you can assure them that they won't get all the thing they might do it. What else? I don't know. You know, so certainly, congratulations on methadone. I mean, I tried to get methadone into this clinic, and I was on the floor of the recovery center, and the recovery center was like, flat out against it. So great on the methadone. I mean, the cost of just the transportation is zillions. And the other, so what I did do a few years ago as a volunteer, I made this grief camp for children. I got
Remember that? Yeah.
Camp Chrysalis. This was any child age 5 to 17 that had lost anybody due to any reason whatsoever. Came to a 3-day camp. That was amazing. Hospice started since COVID. Now they're doing everything. But I would tell you that a third of the kids that were coming in, they had been lost to child. And I'll put it in writing to you, but a program I would recommend is called Camp Mariposa. And it's 5 weekends for children aged 9 to 12 that are affected by child abuse. They don't have, nobody has to have died. They just have some effect of substance abuse. And it's 5 weekends in the year here in the county where they live. Kids 9 to 12 that the Moyer Foundation is the structure on it. That's who the funder is. So, good luck, everybody. I'm certainly interested in offering whatever I can on any part of the issue, but
We really so appreciate you coming.
Absolutely.
Wendy and I bumped into you a few days ago and really put the push on you to come, and I know you rearranged.
I've had some communication with John, but I'm not really a Zoomer, right? So I'm much better, like, in person.
I feel your pain. I'm the same way.
So-
Yep.
And I think
I appreciate
thank you.
COVID going away. Yeah.
We appreciate those insights because I think that kind of demonstrates how some of these issues are. The services in place, services disappear, and 20 years later, we're reaping the consequences.
Well, the danger was the county. The danger was the county saying like, well, it's not mandated, you can't do it. I was like, wait a minute, do you know how much money
Right.
you do? That's a teen parenting program alone.
Reach into the choir.
Yeah. Did you hear Karen? She just said three, yeah, it's.
That's tough.
If I were to win $1 million playing a lotto that I don't play, I would have a maternal child clinic, dream home that I keep talking about.
There's, John is,
Voting again?
he's exploding again.
No, Diane, I want to give you a hug right now. All these points that you brought up, I don't know that I heard the word opioid once in what you said, but so many relevant topics there. With regard to, child abuse, one thing I would love to say, on behalf of my folks and Melissa and her team as well, is, we have a small but mighty force, that is working on these issues, that is aware of these issues. We know what, the county had done in the past, and, my limited history with the county, my understanding is that a lot of these things kind of fell apart with the Great Recession, and we're just now really building those back up. So these bonds between Child Protective Services and maternal child health, and changes in the law have made things, certainly more complex for us all to deal with, whether you talk about Families First Protection Services Act or even bail reform. It makes bringing parents to the table and making things, creating better outcomes for children, it makes it harder to do. But we're definitely working on it. And, the one thing for the public benefit and for the sake of future advocacy is, I put in the Department of Social Services budget to add caseworker positions last year. And I was given support on that, to put caseworkers back into schools so that there was direct contact between Child Protective and our schools. Bob Dufour and his folks have been great partners with us, and we're continuing to build that relationship back to the point where it was when you were in government. But with the struggle we faced is we're dealing with all this in an environment where it is very difficult to recruit people into the social work field. And this is something that Melissa and I have worked very hard on, trying to get salaries boosted, and we've had some success there. And just in general, getting the word out on while it may be a difficult and complex career, it's certainly very rewarding. So a lot of things have been worked on to bring more social workers into the government and into support for these folks. And if you know a social worker, if you know somebody that's about to go to college, please encourage them, because we could definitely use them. Melissa especially. I'm very fortunate with what I've been able to do in DSS and the folks that have raised their hand to come work with us. But there's also, because of the nature of CPS, it's a very high turnover field. So we're always looking for more people, both Melissa and I, and we definitely would appreciate everyone's support on that.
And one of the great things too, is the program now at Sullivan Community College, or SUNY Sullivan, that graduates from high school in Sullivan County can now go there free of tuition, which is phenomenal. And Melissa and some of the team at SUNY Sullivan worked very hard to shore up and expand the entry social work roles, that's just phenomenal. I mean, I think it's the only one in New York State, and I think there's only seven other programs in the country, and we have one here.
Yeah, is there a teen parenting program in Sullivan now?
I can't, Melissa?
Mm-hmm.
Yeah. I mean, because this was also interesting, right, having the teen parenting program. 100% of the teen parents were of families of substance abuse. Might not be opioids, but of alcohol.
Sure.
100% of the teen parents had substance abuse families that they had generated from to live with. Okay? So I mean the teen parenting program again is like essential, right? Essential. And we had a summer program for that they had to learn to cook breakfast, open a checking account, do laundry, and get a driver's license.
Fantastic.
Why maybe they get a driver's license? They don't have cars. Yeah, they have jobs. So it's like it's so many things, right? For this.
And we provide those services
Good.
with our preventive contracts and foster care system. Not classes per se, but really direct to the mothers. Because I think actually statistically, teen motherhood is a bit on the decline. But we still, I think what's especially relevant about what you say, and Jen and I certainly talk about it a lot, is the generational aspect of this. it comes. There was a family that grandmother was challenged, she passed it on to mom, and now we're seeing the kids. And I have workers in child welfare that have been with the county for, some of them in excess of 30 years, and they have seen those 3 consecutive generations
Yeah, now there's
going through the trying to break.
And you see it repeatedly in the drug court reviews. You see that, I mean, I don't want to give a statistical number, but I can tell you the majority of the people that are there grew up, and it was their parents and their grandparents that it's heartbreaking. So, yes, Ms. Kateria, come on up.
I'd like to put my colleagues on the spot with a question, if I may. Out of that 86% or 87%, do we know their employment status on them? We do not. Because there's a direct correlation to, if we can get healthcare services to those individuals, right? Obviously, these individuals have a percentage of them have to be working, right? In Buffalo, in Erie County, and in Albany, they have mobile vans that go to the communities that are at risk the most, right? Through grants and so forth. They have the mobile Veggie-mobile, which teaches them how to cook, and if they sit through the presentation, they'll get a voucher for healthy food. How feasible it is for us to get a grant to partner with providers in Middletown or elsewhere?
Well, we can look also, one of the other members of the CARES Pillar brought something, what was it, Illinois? They had that, but also I think that would be a wonderful proposal to submit for the opioid funding second phase.
And
No, I think that would be, I really do, I think that would be, let's work on it and put it together, so that'd be great.
I have more saddles, so St. Peter's is very progressive in Albany.
Right.
What they would do is, because obviously healthier employees lead to healthier outcomes. What they would do is, if their employees took their lunch break and met with their doctor for their regular checkup, they would waive their copay. So they would show that their employees' workforce would have better outcomes. So we think if we hit up where everyone's working, the county, the hospital, the chicken factory, all these places, and we have the van there and an announcement goes out, we have 20 slots for the day available, right? If you take your lunch at these slots, we'll waive the copay, go in, get your regular checkup, or we can do prenatal care, during those times. But the thing is getting providers to work with us and then getting the van.
Well, actually, that one provider that I referenced earlier on, we spoke about the van. She's very interested in doing something like that. So if maybe some resourceful people could scoff some of that structure that's already done. Why reinvent the wheel? Use some whiteout, put some names on it, and let's see what we can look at.
I'd also invite you to turn around and look at Amanda here in the,
Yeah.
So, Amanda and I, have joined with, actually, Laura quickly was here, she left. But we've been working all together in a group, that Cornell has orchestrated on food insecurity. And a lot of what we're talking about there is logistical issues of, how do you get a truck, how do you get frozen food, how do you get healthy food out instead of just, shelf-stable mac and cheese and that kind of stuff, right? So I know Amanda has a lot of thoughts on this, but there's already a good cooperation going on there, that I would love to see move some more of these kind of ideas forward in making sure that we're not just getting calories to people, but we're getting health. I'd love for you and Amanda to connect on that.
And prenatal services.
Yeah. Okay.
Anybody else? Thank you, Kateria.
Karen, did you have something to add?
Can you imagine that you would have something?
I mean, I do. We could go on. We know that time is running short.
Well, is there any other questions from the floor? Hey, it's all yours then. For 3.5 minutes.
Feels like you're good?
Okay.
So I think, just as we wrap up, again, I want to thank everyone. I know it seems like we're talking about 100 different issues. That's the point. Because we're not going to fix the problem that everyone sees, which is burying our friends and neighbors from overdose death. We're not going to fix it without talking about these 100 different issues. Not a one-size-fits-all. So I think even though it seems like we went from A to Z today, I think it's important, and I appreciate all of you engaging on all of these topics. And if there's one in particular that you feel strongly about, want to get involved in, reach out to Wendy. I think her email address is up here, and she can put you on a pillar. Those pillars are having much more frequent meetings, and then every quarter we have a lead meeting, and then how often, I think every 6 months we have this open meeting with the public. So these things that are happening are the culmination of so many individual conversations. So I appreciated today's meeting. I think actually we had a lot more engagement than we did last time, and it's really helpful. I also want to say, I want to end on a hopeful note, because we can come here, we did this in our last pillar lead meeting, we left at 5 o'clock on a Friday completely depressed. We shouldn't be that way, because these problems existed before we came together as a group, and no one was doing anything about it. So at least we can have hope now that people care about it to do something about it. So I want to end on a hopeful message. I just want to give a quick explanation of why I grilled these guys, because I think it is shocking information that Jen and Karen are dealing with every day, and it's not getting the attention it needs. And we had this conversation this morning that the pillar system, one of its greatest strengths is that when one pillar needs vocal advocacy, the other 7 show up. So I think at this point, there's really an urgent need to show up for maternal child health. And if we all do that, we can help make some change. So that was one of the reasons, you know, it wasn't designed to depress everyone, make everyone. It was designed to help us ask them what they need and what we can do to help get that done. So thank you again, everyone. We look forward to seeing you again real soon.
Thank you.